She's one of our new faculty members of the last few years and went to medical school in GW and then was doing her training here and became a rheumatologist in our fellowship. She's been sorting out what her focus in rheumatology has been, and certainly lupus and rheumatoid arthritis are many of the patients she's seen, but she's been doing a little bit of research with me in scleroderma and has authored a couple of pregnancy in scleroderma papers, both for patients and for doctors. And so I think that's a good segue to go into her talk on pregnancy and rheumatic disease. Thank you, Jessica.
Pregnancy and rheumatic disease, right? So my main goal is to kind of communicate the idea that pregnancy is really possible for almost everyone with rheumatic disease. You know, and more applicable to even the world outside of rheumatology, when you see a female patient, I want you to be able to consider what her pregnancy plans might be in your care for her. Just have it on your radar. When you see a patient with rheumatoid arthritis and lupus, we're going to talk about the contraception, and we're going to talk about pregnancy outcomes in both of those conditions, as well as certain medications. So these are our guidelines, right, that just came out. They were kind of in the works for most of 2019, and finally we got them out in April of this year. And you'll recognize my boss here, right, Dr. Steen is part of this. So some big themes here. In your patient's eyes, the desire for a pregnancy may very well outweigh the risks of her disease. You know, it's in your best interest to be an ally to her in that regard, right? All right. So and then just more applicable to general women's health overall, right? More than half of the female population, or more than half the population of the United States is female, and near 90% of them will have had a child at some point in their lives by their mid-40s. And now they're waiting longer and longer to have children. So really, in premenopausal women, you should be considering this and thinking about asking them about this when you're seeing them, when you're prescribing them medicines, and when you're considering how you're going to take care of whatever chronic medical condition they're dealing with. Right? Right? We call it women's health as if it's a subspecialty issue, but really, pregnancy is normal. Women's health is just health. It's normal. And you need to consider that pregnancy is a normal life event that's going to impact more than half of your patients in all likelihood at some point in their lives, and it has a significant impact on their medical problems and what medications you use. So the residents humored me and answered a poll I sent out to them last week about just in general, how are they approaching premenopausal patients when they see them in clinic. So I asked them, if you're seeing a healthy patient for a health maintenance exam, is she going to tell you that she wants to get pregnant? I think they're probably right on here. Probably not most of the time. They might mention it, but it's a normal life event for many people. And if they're healthy, they likely won't find a need to, right? If you're seeing a person with one or more chronic medical condition, do you think she's going to tell you that she's planning on getting pregnant? And again, in all likelihood, probably not. Pregnancy is a normal part of life. People don't necessarily think it's something that must be shared with their primary care physician. So that being said, even though our residents are expecting that their patient's probably not going to tell them, and they're probably not going to tell them, they might tell them a little bit more often if they're on a medication to check in. Fair enough. So what are we doing about that? So I asked our residents, do they ask their premenopausal patients before they prescribe them any new medicines? And a little bit, mostly not though. So I'm hoping that I accomplished my goal here of making this point just by having you guys take the survey in the first place. That really just have this on your radar, think about it, ask them, right? If nothing else, even if it's not going to change your management of that problem, it will allow patients to ask you questions that they might be fearful of asking. For a woman who wants to have a baby at some point, to hear from their doctor that there's a reason they can't or should not, a lot of times they'd rather not hear that information. And we'll talk about that a little bit more in general. So first, let's touch on rheumatoid arthritis. As you know, rheumatoid arthritis is a symmetric polyarticular arthritis, usually small joint predominant. Most of our patients will have a rheumatoid factor or CCP antibody that's elevated that helps us make the diagnosis, although many times it's clinical. Our treatment philosophy for this is we start them on medicine right away because not only do we want to help their pain and their function, but we want to prevent the erosive, deforming damage that occurs in the long run with this condition. So here's a patient of mine that I saw, Michelle. She's 32. She had several months of morning pain and stiffness in her hands. Ibuprofen helped a bit, clear synovitis on physical exam, and lab studies do confirm a diagnosis of rheumatoid arthritis. So we get her started on methotrexate, one of our standard first-line medications for rheumatology patients, right? So she comes to you for her routine health maintenance exam. So what do you need to ask her? For someone on methotrexate, contraception is hugely important. So you ask, what are her pregnancy plans? So she's sexually active with her fiance only. They have no immediate plans for children in the next few years. And she's on the pill, she's taking oral contraceptives, but she's not that great about it. She forgets occasionally. So the first thing I wanted to mention here is the most important thing you have to do is ask the question, what are your pregnancy plans? And it'd be very easy if these were the only two answer choices, right? Yes, I want to get pregnant now, or no, no way I don't. This is more the reality, right? Maybe I do, maybe we'll try, maybe we'll not try to not try. Huge spectrum. And probably, as most of you are female, probably a lot of you have been here somewhere on the spectrum at one point, right? So understanding where a person is on this trajectory, if you will help guide your contraception choice and my choice as a rheumatologist for what medication we're gonna start. So we're really bad at asking this question. We're really bad at having these conversations with our patients. This is mostly about rheumatologists, but probably we could all stand to improve this, right? A recent focus group, this is in 2019, this was published, a recent focus group that looked at rheumatologists from all across the country and asked them, what are the obstacles to care? What frustrates you about talking to rheumatology patients about pregnancy? And they said they were frustrated that their patients become pregnant when their disease activity was high. They are frustrated that their patients think that all medications are bad. They're frustrated that their patients don't trust what they're telling them, and they feel like their patients are not communicating with them very well. Do you see a theme there? A lot of blaming on the patient. Probably is a good sign that we're not doing a good job of communicating our role. So the counterpart of this article was that they also had a large focus group of women with lupus and asked them what the obstacles they perceived were. Those patients, not surprisingly based on how the rheumatologists were feeling, the patients said they felt intimidated and therefore they were not honest with their providers about their plans for pregnancy, right? They felt that discussions about pregnancy were very serious, very fear-laden, and they felt a lot of guilt about wanting what they wanted in regards to any desires for pregnancy. Yes, they do. You probably knew this. This is the case probably with most things we tell our patients. They look it up online afterwards and confirm. And, you know, when they dug down into this bullet point here a little bit more in this study, really the main issue was that, you know, they were receiving different messages from different providers. So we all need to be educated this and understand. Absolutely, I have had patients who I put on hydroxychloroquine for their pregnancy intentionally. Then they go to their GYN, they go to their primary care doctor. That other doctor panics and tells them to stop everything. And then I have to undo all of that damage. We need to all be educated. We need to know what we don't know. We need to work together. An important message that came out of this from the lupus patients, if they want a baby and they really, really want a baby, to them, that'll often be more important than the risks of pregnancy. You know, and rather than alienating your patient, if that's the way they are feeling, you'll do best by them if you if you take care of them and you work together with them to figure out how can we get you through this, right? So let's cycle back around to our patient. She's on methotrexate. She's not doing that great at her contraception. Not an uncommon scenario in my world at all, right? So this is a study of patients who, this is a study of pregnancies for folks who were exposed to methotrexate sometime within the 12 weeks prior to conception and then several weeks post-conception. So the big issue with methotrexate is that it causes miscarriages. So 42.5% of those exposed, so this top red line here, is anyone who was on methotrexate for a time after they conceived. 42% of them are going to have a miscarriage within the first several weeks of the pregnancy. After that, the risk of major birth defects is still unacceptable at 6.6%, but that's not the main issue here. The main issue is the early miscarriages, right? And if you will notice, the other observation to make here is that after 12 weeks, this line plateaus, right? So it's really early on. If you have a patient who makes it to the 12-week mark after a methotrexate exposure, of course, as soon as you realize they're pregnant, you stop the methotrexate. But you can counsel them from here. This is a risk of birth defects. This is where we're at with that. Once you've made it to 12 weeks, the likelihood of losing that pregnancy is really low after that point. All right. So what contraception should you recommend for her? Really, for rheumatoid arthritis patients, there's not a specific restriction. There's no specific medicines they should or shouldn't be on due to their underlying autoimmune disease. Generally, for methotrexate in particular, we recommend IUDs. They're just more reliable and more effective. Of course, that's a lot of personal preference issues for the female as well to be taken into consideration. The main goal is to have something that works. One other medicine worth mentioning in regards to contraception is leflunomide, or Arava is the brand name of this. We use it somewhat similarly to methotrexate for early rheumatoid arthritis, one of our first-line therapies. I often will wind up using it if patients are not able to tolerate methotrexate from a GI perspective. This has a very, very long half-life. It undergoes enterohepatic recirculation, so the elimination half-life is very long. It's about 20 days. There actually has not been a lot in humans to show that this is dangerous, but there were significant issues with congenital anomalies in rodents exposed in utero. While there hasn't been a specific pattern of anomalies in humans, it is a medicine we discontinue immediately if we find out somebody is pregnant. And because of the recirculation, you really have to do a cholestyramine washout. So you give people a course of cholestyramine for 11 days here. Sorry, the Google format has this. This should be cholestyramine TID for 11 days. And then you check a teriflunomide level, which is one of the metabolites, and make sure that it's out of their system. And then after that, people generally do quite well. We have safe options though. So really, the best method of this whole thing is picking the right thing right off the bat, right? Sulfasalazine, we don't know super well exactly how that works, but it is safe during pregnancy. There's a lot of data for this for IBD and for arthritis patients. No issues with adverse pregnancy outcomes. Hydroxychloroquine, America's favorite medicine. I liked it before it was cool. It's great for pregnancy, great for autoimmune disease. Very safe. We've used it for years in lupus and rheumatoid arthritis patients, and there's no increased risk of birth defects. Every once in a while, I've gotten an OB who feels very scared about hydroxychloroquine. There was some studies, mostly in rats, that showed potential issues with fetuses being born with some retinal issues, but that really hasn't been demonstrated in people. And this is one of those things for, especially for our lupus patients, as we'll get into later, preventing disease flares is like the much more crucial issue. So Michelle comes back for a follow-up visit. She did okay with her methotrexate. She improved a fair bit, but she is still using quite a bit of ibuprofen. And you were supportive. You talked to her in detail about her hopes, so she feels comfortable coming to you to let you know that she's hoping to get pregnant in the next few months. So her rheumatologist is planning to switch her over to a TNF inhibitor, a biologic, because of course the methotrexate is not safe for pregnancy. So one thing I want to mention, a lot of our patients, both with rheumatoid arthritis and otherwise, are on anti-inflammatory medications, and at least intermittently. The Paris study is a big cohort study nationwide, looking at pregnancy, contraception, different outcomes like that around rheumatoid arthritis. The study was one to demonstrate that subfertility, which is defined as it taking more than a year to get pregnant, requiring in vitro fertilization, requiring help to get pregnant for any period of time. So about 46% of those in this study with rheumatoid arthritis reported at least one episode of subfertility. Only a third of the patients took less than a year to get pregnant, and another third took about 12 months, and the remainder really needed some kind of fertility treatments to get pregnant. An interesting thing that came out of this, that of the women who experienced subfertility, a large proportion of them were on NSAIDs chronically versus only 17% of those who did not have issues. So I usually recommend to my patients with rheumatoid arthritis and any kind of arthritis who want to get pregnant that they try to reduce their NSAID use prior to pregnancy. Honestly, if they're needing NSAIDs that much, I'm probably not doing my job well enough anyways. Now there's a little bit of, this was a retrospective study, so patients reported back on prior pregnancies they had. And it seemed that the more of the respondents that they got were more of the folks who took, who had relied on fertility treatments. So I think there's probably some reporting bias here, to be sure. But this notable difference with the NSAID, I think, is the main thing to take out of it. Let's see. So another question I asked our residents: is it dangerous for a patient with rheumatoid arthritis to become pregnant? Most of them knew, no, indeed it is not. But there were some folks who were not quite sure about it. So let's go through this. How do folks do? How do folks do in pregnancy if they have rheumatoid arthritis? So overall, they do well. There's only subtle, slightly worse outcomes than the general population. And the general theme with this, as with most autoimmune diseases, the better controlled it is prior to pregnancy, the better the pregnancy outcome. This study showed a slightly higher miscarriage rate here, but there's an asterisk to this. These were a little bit older patients, so arguably the comparator group might not be the best. And the estimates in the general population fluctuate hugely depending on who you're looking at, but not a major signal there. Rates of preeclampsia, not statistically significant. Rates of cesarean delivery are a little bit higher, as are preterm delivery, but these increased risks are seen almost exclusively in patients who had high disease activity. So if you've got someone who's well controlled and who's doing well, you wouldn't necessarily expect this. Of course, all the data with C-sections is always, you know, for women with chronic medical problems, I think there's a tendency to jump to that a bit more quickly. So that's always part of the thought process there too. Okay, so now some of you may have heard rumors or heard this idea that pregnancy puts rheumatoid arthritis into remission. This has actually been observed for a long time. So a Dr. Hench back in 1938 was one of the first people to observe this and published a paper on it. Since then, there's been tons of observational cohort type studies, not super great as far as study design, that have demonstrated this. So the classic teaching is that more than half, some studies as high as 95% will have improvement in their symptoms during pregnancy, with a solid proportion actually achieving remission. So is that real? So we have neuro data, again referring back to the Paris study, this large cohort study across the country of rheumatoid arthritis patients in pregnancy. let's see. So in this study, indeed, so the DAS-28 score is one of the scoring systems we use to determine the severity of rheumatoid arthritis, right, to track over time. A DAS-28 under 2.6 is clinical remission, and then this darker gray box here, that's low disease activity, the white moderate disease activity, and the gray is high disease activity. As you can see, about 48% of those who started with active disease, so like in this big white column here, they do improve. So there is quite a few people who improve. But you get to third trimester, we still have half of the patients who are in moderate to high disease activity. And there are a percentage that are in remission that goes up. The big thing here, if you look at those in this group here, the highest disease activity, that stays steady right through. So really the big thing here, how you do depends on your pre-pregnancy disease activity. So what are we going to use for her? We have TNF inhibitors, which are usually our next step for those refractory to methotrexate or who don't tolerate it. We've got lots of options here, some of which I'm sure you've at least heard of before if you have a television. The current guidelines are a conditional recommendation to, if you have good disease control with what you're on, you keep it during pregnancy. So let's talk about a few of these specifically. So adalimumab or Humira is a monoclonal antibody that's humanized. So structurally, this part of the antibody is very similar to all the antibodies that you just naturally make. Now, during the first trimester, this does not cross the placenta. The placental FC receptors are not fully developed, so this really gets very little into baby circulation. But second trimester moving forward, baby is actively pumping antibodies across into baby circulation as a means of protecting themselves. That way baby can be born with some of mom's antibody protection. Humira is an antibody. It gets pumped across just like anything else. So what this means is that if you continue the Humira all the way through, babies are born with super therapeutic levels of the drug in their system, which, you know, sounds scary, but it actually has not been associated with adverse outcomes in baby. Theoretically, there's a risk of infection, but really that has not been demonstrated. I found a case report of a baby dying who the mom had been on infliximab throughout pregnancy. I had read a report of a baby that died from disseminated BCG after being vaccinated with that very shortly after birth. So there's a kind of, if mom is on Humira, there's we delay the timing of any live vaccines, but based on a theoretical risk of infection that hasn't actually been seen. So if you have someone who's been real difficult to control, probably worth just leaving the Humira as it is. We do usually stop several weeks before delivery, just as a means of preventing infection in mom during delivery, but the data regarding that is not great either, right? So if you know your patient wants to get pregnant, my philosophy is you just start them on the right thing off the bat. So Enbrel is potentially a better option. So it's got a structurally different FC portion, still humanized, but structurally different, and it actually lacks one of the important domains for placental transport. So very little crosses the placenta. It's also, this table here is from a study that looked at the amount of Enbrel in breast milk, and as you can see, compared to mom's serum concentration here, it was held during childbirth here, so there's a little bit of a drop, but then you see she kind of gets back to a steady state. Very little relatively in breast milk and none detectable in baby's serum. So this is one you can feel confident about through pregnancy and with breastfeeding as well. Okay, so Cimzia is another one we have, certolizumab pegol. So this has a pegylated portion attached to it here that prevents, the intent of that was to make the medication last longer in circulation. So you can give Cimzia just 400 milligrams every 4 weeks, lasts longer than the other. But one of the perks of this is that it does not cross the placenta in significant amounts. And it's a bit of a unique medicine because we do have 2 industry-sponsored trials to actually test the pharmacokinetics in pregnant women and breastfeeding mothers. So, you know, women in general are underrepresented in medical research. Pregnant women are essentially non-existent, and there's a lot of reasons for that, of course, but it leaves us with this big data gap. So this was nice that they did that. So often I will try to get people on this medication right off the bat. Now, one issue with that, if we're choosing between Enbrel and Cimzia, not to mention that nobody's insurance wants to cover Cimzia, I find, and this is Cimzia, right? It's a self-injecting, it's a pre-filled syringe. Whereas Enbrel is this nice little auto-injector where you just take off the cap here, you push the button, and you never see the needle. So sometimes this one is a tough sell. Enbrel is, of course, an effective choice for rheumatoid arthritis too. So, any questions about rheumatoid arthritis, you can send me a chat or anything like that. But in interest of time, move on. So to our lupus folks. So this is a real patient of mine as well. Names have been changed, of course. Brianna, she's a 26-year-old. She has lupus. She's had it for a long time. She was diagnosed as a young teenager. She had nephritis in the past that has been stable. Right now, she mostly is dealing with a lot of arthritis, rashes, and alopecia. She's had pericarditis a few times over the past year. She has a hard time taking her medicines. A lot of them upset her stomach. She forgets a lot. And right now, she's currently sexually active with one male partner who she's monogamous with, but he is not monogamous with her, and she doesn't use any protection. So she is coming to you to discuss contraception options, and I have recommended she consider an IUD. So you kind of wonder, well, this gentleman is not monogamous with you, you're not using any protection. Where are you on this spectrum here, right? And that's the first step of what you need to figure out in recommending contraception for her. The next big consideration is, well, what medications is she on? How serious are we worried about what would happen if she got pregnant? Right now, she's on Celsep, mycophenolate mofetil, 1,000 milligrams twice daily. She's been up and down on this prednisone dose, but at this moment in time, she's on 10. She's on Plaquenil, and she takes ibuprofen fairly often. Periodically, she stops all of her medications for a week or two, usually because her GI upset gets too bad, and she has a hard time sticking with this plan. So now her labs do show she has arthritis on exam. She's got active disease. Her labs show elevated dsDNA antibodies, low complements, and some ongoing proteinuria. So contraception in lupus, how do we decide? What do we need to know? What do we need to worry about? One of the important things you need to know is about a patient's antiphospholipid antibody status. So antiphospholipid antibody syndrome is defined by the Sapporo criteria here. So these are the patients who have those high titer anticardiolipin IgG or IgM, beta-2 glycoprotein 1 IgG or IgM, or a lupus anticoagulant, and they've actually had the clot or a pregnancy issue. Many patients with lupus have high titer antiphospholipid antibodies without having antiphospholipid antibody syndrome. And it's part of the lupus diagnostic criteria, right? So that's something you need to know about. Which category do they fall in? So let's talk about those without the antibodies or without the syndrome first. So if you have lupus, you don't have any antiphospholipid antibodies, and you don't have any phospholipid antibody syndrome, and your disease activity is low, there's really no restrictions. You can use normal hormonal contraceptives. You can, really the goal is just be on something effective. If you're on a medicine like mycophenolate, which is highly toxic to a developing baby, they recommend an IUD or a progestin implant just because of the effectiveness. Nothing really to do with the lupus otherwise. If you have lupus without these antibodies or the syndrome with moderate to high disease activity, it's more strongly recommended to be on a progesterone-only contraception or an IUD. And this is strongly recommended based on kind of historical evidence that estrogen might be triggering to worsening lupus flares. It honestly has not been very well studied, but as the IUDs are more effective contraception anyway, and if somebody does have moderate to high disease activity with lupus, the odds are you may need to start them on a medicine that could be more toxic to baby too. Really, the estrogen lupus connection is one that's tricky and not as well studied as we would like it to be. And let's see, so for those with antiphospholipid antibodies, but without antiphospholipid antibody syndrome, we do recommend avoiding any estrogen-containing contraception in them. And this is something you have to look into. The patient will not necessarily know this. And I've had many patients who've come to me from other rheumatologists where this hasn't even been checked. So you have to, if they have lupus, it's a slam dunk. Otherwise, they've never had a clot. Maybe nobody ever looked into this. But when you're picking what contraception they could be on, if they have an antiphospholipid antibody, they have a little bit higher of a risk, even if they don't have the syndrome. And the estrogen containing compounds can be the second hit that causes them, that could set them up for a blood clot. Of course, those with antiphospholipid antibody syndrome should not be on any estrogen containing contraception. I think it was on the last slide that I didn't mention. In general, there's also a recommendation for lupus patients to avoid alternative delivery methods of estrogen-containing contraception, so like the patch, the ring, that kind of thing, because we just don't know as much about them in lupus patients specifically, more of a lack of data issue. And there's been some concern that could the depot shots increase risk of thrombosis. So not great data, but the advice is to avoid that in antiphospholipid antibody patients of any type. All right, so let's talk to her more. So you notice that her disease activity is pretty high, but her antiphospholipids are negative. And you really are trying to ask her more like, wait, what's going on with your pregnancy plans? Like, how do you really feel about this? So at the time when she was diagnosed, one of her doctors told her, you will never be able to get pregnant. I don't know why they told her that. I don't know what was happening at the time that made them think that, but that's what she was told. And I've had that experience with many lupus patients. Many lupus patients have been told they can't or they shouldn't or somewhere in between, and they got that information. So she says, it's really not the right time in her life to be getting pregnant. This really isn't the right guy, but she's so scared that she will not be able to have a baby someday, and she really wants a baby someday. So she would rather not use protection. And this is really the way this story ended. I sent her to the gynecologist for an IUD. She sounded like, yes, let's do it. But then she came to my office one day complaining of nausea, breast tenderness. I knew she'd been having unprotected sex, so we were worried she was pregnant. We did a urine pregnancy test, and it was negative. And I thought she would be like, oh, thank God. And she started crying because she was so upset that she wasn't pregnant. So not the best situation overall, perhaps not the way you want to do it, but we have to adapt what we are doing for her based on where she's at with this. So same deal with lupus and pregnancy as it is with rheumatoid arthritis. Pre-pregnancy outcomes are huge. So let's go through some of this. Asked our residents. Yeah, a lot of them were like, yeah, this is probably a little more dangerous with rheumatoid arthritis, but I was very happy to see that many of you disagreed with this statement. So let's talk about that a little bit more. So what happens when lupus patients get pregnant? A lot of the data we had until recently was kind of these large meta-analyses going back over years. A lot of times they involved kind of university rheumatology patients, right? A lot of times they're sicker, a lot more nephritis, a lot more bad lupus that the community docs couldn't handle, right? So 25% will flare, right? And now the big theme of this is that Nephritis was very much associated with many of with the preeclampsia risk, with the hypertension risk, with even increased maternal death and things like that. So a history of nephritis, especially active nephritis, was a big risk factor for all of these other poor outcomes. We do know that there are more premature births as well, more tiny babies in lupus, to be sure. Overall, in this large meta-analysis of 2,751 pregnancies, 23.4% of the pregnancies were not successful for one reason or another. And that doesn't include people who chose to terminate, say if they were on a medication that required it. And the other thing they didn't really look at here was how they didn't kind of break it down too much about the antiphospholipid element. We know that antiphospholipid antibodies are associated more with unsuccessful pregnancies and preterm birth, and also with hypertension. But we have a little bit of better data now. So the PROMISE study was big. So they wanted to look at, so we know how bad lupus patients do in pregnancy. Some of them do okay, but it's not great outcomes. You worry a bit. So if you have a more normal clinic lupus patient, they're doing pretty well. They've got a little of arthritis. They don't have nephritis. They don't have life-threatening manifestations of lupus. How do they do during pregnancy? So in this study, they took a group of pretty well-off lupus patients doing okay. It was a prospective study, so they enrolled folks up to 12 weeks of gestation, and they took out patients who even had some chronic proteinuria. They had a pretty strict renal limit. They couldn't be on higher than 20 milligrams of prednisone a day, right? And how did they do? So for the subset of patients within this group that were particularly low risk, and these were traditional kind of risk factors that we already knew about in pregnancy, essentially the white patients who were not on blood pressure medicines, who did not have a positive lupus anticoagulant, and had a good solid platelet count with low disease activity, they did great. Now, important thing here, this white column here, the control participants, these were specifically women's picked because they were particularly healthy. They had no medical problems. So it's not, the control group is not the general population. The general population is this dotted line. So really, in a lot of outcomes, the if you will, healthier, the lower risk lupus patients perform pretty similar to the general population. Some risk factors here, like who were these people within this relatively healthy group of lupus patients who have any adverse outcomes? A lot of them were patients who had antiphospholipid antibodies, particularly lupus anticoagulants, and some other risk factors were just African American race, high BMI, if they had any prior fetal death, prior renal disease, or prior clotting issues. But really, overall takeaway, if you have a patient with lupus who's doing well, who doesn't have a lot of these other risk factors, the odds are they'll sail through pregnancy pretty well. So a few quick things on pre-pregnancy evaluation. One thing you have to think about is SSA. In crossing the placenta, it can cause neonatal lupus, which is this rash here, potentially some hematologic abnormalities, and there's a risk of congenital heart block. Any patient with an SSA should be on hydroxychloroquine during pregnancy based on some evidence, not super strong, but some evidence that it can reduce the risk of congenital heart block. So you talk to Brianna about what you want to do. We're going to stop that CellCept on her. She's not really taking it anyway. Let's talk about CellCept. Highly teratogenic. This is more teratogenic than methotrexate, right? Significantly so. 42% will have congenital abnormalities, and there's a particular pattern to them as well. So we know this. This should be discontinued at least 6 weeks prior. We say ideally 3 to 6 months to make sure that they have well-controlled disease on another regimen. Plaquenil, right? Safe, we talked about it. It does good. In lupus patients, it's super important. We know they have fewer flares. They do better in their pregnancies if they're on Plaquenil, right? Risk of disease outweighs the risk of the medicine, which is not very much. So let's see. So we're going to switch Brianna. She's going to keep her Plaquenil. She's going to stop her mycophenolate. And here's some of our options. Azathioprine also has lots of experience during pregnancy, although not well studied. It has not been associated with congenital abnormalities. I know my transplant colleagues will use this frequently if they're transitioning somebody in anticipation of pregnancy off of CellCept onto azathioprine. Let's see. So another thing to mention, we do put lupus patients on a baby aspirin a day. In general, in pregnancy, because it lowers their risk of preeclampsia. You don't need to do this in RA and other rheumatologic disease that don't share the preeclampsia risk that lupus does. And of course, anyone with any phospholipids is on this as well. The risk is low, it's worth it. Some bad ones, cyclophosphamide, of course, significant birth defect risk. This needs to be stopped a long time before. Prednisone, we can use this in pregnancy. It doesn't heavily cross the placenta, right? That's why you have to give the betamethasone for lung maturity for babies, right? So we can even use low doses of prednisone throughout pregnancy to help control arthritis. Rituximab is an interesting situation. So it is a monoclonal antibody, but as you know, we only give it every 6 months. It's minimally transferred across during the first trimester. So we can really use this in early pregnancy, before pregnancy. The limited data that we have seems that people do well. And a lot of folks do continue it during pregnancy. Belimumab, really, we have no data, but it's also a monoclonal antibody. So theoretically, there's ways this could be used as well. We need more data. That's the message. So what we did for Brianna is we put her on rituximab. She's gotten, at this point now, she's had 2 cycles, and it's actually been much better for her joint pain and her pericarditis, probably because she's actually getting the medicine. So summary-wise, female patients are normal patients, and pregnancy is a normal life event. Just keep it on your radar when you're talking to your patients about anything, right? When you talk to your patients about this, they'll feel more comfortable volunteering the information and telling you about concerns they have. And remember, when you're having these conversations, in your patient's eyes, the desire for pregnancy may very well outweigh the risks of the disease. Be on the same team. You guys can work through this, right? We can figure out what's best for everybody. Pre-pregnancy disease activity, super important, right? Get them in a good place and then go for it. And then this element of how risky is the disease to the pregnancy is something that really needs to be expressed to patients as well, so they understand why you're telling them to be on medicines. Remember about the harm of a disease flare. Significant nephritis flare in lupus can be a catastrophe, but if you have them in a good place, on Plaquenil, cruising through pregnancy, they can get through it.